that I forgot to do when we were doing the pelvis, the IEX, and then we'll move into the cervical. So with a short leg, let's say that we have a short on the right, bring it into flexion and stay short. He rotates his face right, center, left, center, and there's no change. Check the trigger points are absent. There's nothing going on with the lumbars. Safe restriction, it's good. There's nothing going on there. Check the gastroc, that's good. Bring him up. Okay, left supine through the chair. Supine, and we check the spinal balance, and if we don't have a thoracolumbar scoliotic condition, then the left leg should be short. Okay, that's a strong indication of an INEX or rotated pelvis. So let's just say that we have the EX on the left side. Let's do the EX. You do either one first, doesn't matter. Set the drops and thrust. And we'll do the IN, lift the leg, move it medial, set the drops, thrust. At this point, the leg should balance. Put him back in the prone position. Also not balanced in the prone position, but bring them into flexion, and they stay balanced, and we just do lots bilateral. Turn face right, center, left, center, they stay balanced. Okay? Yeah, any questions about that one? Yes, ma'am.
When you say you turn a supine, what are you looking for besides?
The opposite leg is short. We started with the right short. When we put it supine, the left is short. And if you don't have a scoliosis, then that's a strong indication of a rotated pelvis.
And the INEX is on the original short leg side?
Mm-hmm. You got the IN on one side and EX on the other side.
That's it.
And you correct them both.
Sorry, thanks.
Okay. Any other questions about that one? INEX, and I think that was the end of the pelvic movements.
When you flipped over and the short leg changed, is the new short leg the side of the IN?
Oh, you'll just have to look at your x-rays and palpation to come up with what size IN and EX. Okay. But if you should get that move on the test, I'll tell you, like IN on the right and EX is on the left. Okay?
So in that case, does it matter which legs are going short, where the activity is?
Yeah, the opposite leg has to get short. If you start out prone with the right short and you put them supine, then the left becomes short.
But that doesn't dictate whether left is EX or I?
No, no.
Okay.
But now you remember that if you have scoliosis, that rules that out. You know, that could cause the same thing. Okay. Any other question about that one? The INEX. Okay. The bilateral. This is what we've done next, right? Bilateral. We will start with balanced legs. We bring them into flexion and they remain balanced. He rotates his face right. When it goes right, the right draws short. Back in the center. Left, the left draws short. Back in the center. Okay. Bilateral cervical syndrome. We'll elevate the footrest there to relax the musculature. We'll set the cervical and thoracic section to drop. The head piece is angled down. Okay, tuck his chin a little bit. And I forgot to mention this. If the patient is wearing removable dentures, you know, you make sure that you have them to take those out before you do this type of adjustment, okay? So we want to contact right on the posterior occipital mastoid groove with the thenar pad. So we come in, it doesn't matter which hand you use first, the forearms rest on the back, and we're just scooping it up because the occipit's gone AS, okay? And we're just lifting it up to bring it PS. After the adjustment, to the post check, the legs are balanced. They're still balanced in flexion. And we'll instruct him to rotate his face right. No change, back to center, left. No change, back to center, and the bilateral cervical syndrome.
So the bilateral cervical syndrome is just where you take the occiput. It's an AS occiput.
AS occiput. Okay. Now I've got to go back. I forgot to do one. We done cervical syndrome after midterm, right? Okay. Let me go back and do that one. Then I have to get to the contralateral. Cervical syndrome. With the cervical syndrome, we'll start with the short leg, and this could be a unilateral cervical syndrome. We have it on one side, or you could have it on both sides. It will be right and left. Short leg, so let's say that we have a right short. We bring it into flexion, and at this point, it doesn't matter what happens. It can stay short, or it can cross over. Okay. We'll have him rotate his face to the right, and let's say it balances out. Right cervical syndrome. To the left, nothing happens. Okay, it stays short. So in that case, we'll come up on the opposite side of the syndrome, and we'll start palpating at the base along the facet capsule, looking for the subluxation or the misalignment. Okay, and more than likely it will be at C2. Okay, because that one's more freely movable than the other ones. Okay? And we can do the adjustment by using this type of move, which is the modified cervical break or prone cervical, however you call it. He rotates his face that way. We'll set the drop and thrust. Or if you wanted to use a toggle recoil method, you will rotate his face this way, and you can do this from the front or the back. Let the LPJ, high arch, toggle recoil, superior torque. Okay? And if we did not find the swelling at the facet capsule, then we'll bring him up and palpate for misalignment of the atlas on the opposite side of the cervical syndrome. And in that case, we'll put him in the side posture and do a side posture toggle recoil. Okay. In the post check, the legs should balance out. We bring them into flexion and they're balanced. He rotates his face right, center, left, center, and they remain balanced. And cervical syndrome. Now, we also can have a right and a left cervical syndrome. Okay? And like the cervical syndrome, we'll start out with a short leg. So let's say that we have a right short. We'll bring it into flexion. It doesn't matter what happens in flexion. He rotates his face right, and it balances out back in the center. He rotates his face left, and it balances out back in the center. That's a right and a left cervical syndrome. And more than likely, your subluxation is going to be in the mid-cervical spine, like at C5, because it could be a C4 or C6, okay? And also at C2 or C1. So we'll start at the lowest one first and see if that corrects everything. So let's say that we had the right cervical syndrome and the subluxation is at C6. Okay. We'll roll in for the adjustment, set the drops, do the thrust, back in the center. Okay. Shake the legs. The right leg is still short, so we'll have him to rotate his face to the right. When he rotates his face to the right this time, nothing happens, it stays short. So we assume that we've corrected that problem. So he rotates his face to the left, and it balances out again, okay? So now we need to go up and fix the left cervical syndrome. So we'll come up on the opposite side. And let's say now this one's up higher, it's at C2. We'll set the drop and do the adjustment. At this point, the legs are balanced. We will bring them into flexion and they remain balanced. He rotates his face right, center, left, center, and they stay balanced. And with this close balance. So in that case, we corrected the right and the left cervical syndrome. They appear there together. Okay. You okay with that one? Okay. The contralateral Deerfield. With the contralateral, like the bilateral, we start out with the legs balanced. We will bring them into flexion and they remain balanced. We'll have him rotate his face right, and when he rotates his face right, the left draws short. Have him rotate his face left. When he rotates his face left, the right draws short. Okay. Now, there are two possibilities for this. We can list this as a contralateral Deerfield, or it can be the hidden Deerfield. Okay. And we'll just have to palpate and determine which ones it is. Usually, if you have a reverse curve, okay, in the cervical spine, like due to trauma, whiplash, and stuff like that, the occiput's going to be sitting in a position like this, where it's going to be, like retraction. Okay. So in that case, we're going to list this as a PS occiput. The headpiece, we would elevate the superior end up, okay, because we want to thrust the occiput back P8 and S to I. Extend on either side, like the bilateral. We're still making contact with the thenar pads. Roll in, set the drop, and this time, instead of lifting the occiput up that way, we're driving the occiput back down that way to correct the PS. Okay? And if it was like hidden Deerfield, right and left cervical syndrome, then we could do the same thing that we just done for the, the right and left cervical syndrome, depending on where you find the hidden Deerfield at. Okay? So after that one, we'll do the post check. At this point, the legs are still balanced. They are balanced in flexion. He rotates his face right this time and they stay balanced. He rotates his face left this time and they stay balanced. And that's the contralateral or hidden Deerfield. Question about that one?
Like, you change the angle right of the drop piece when you're doing the contralateral?
Yeah, you raise for the bilateral, the superior end on the headpiece. If this is superior end, it drops down.
Right, move to the
And if it's contralateral, we'll raise it up.
Okay, so you just were, so you didn't raise it, but you would raise it normally?
Yeah. Well, I said you would raise it. I didn't raise it, but I said you would raise it. Okay? Everyone okay with that one? Next one, Oxford. Okay, we've done the unilateral AS and unilateral PS. Okay? So let's say that we have balanced legs and we bring them into flexion and they stay balanced. Bring them back down, and let's say that he rotates his face to the left. When he rotates his face to the left draws short. Back in the center, he rotates his face to the right, nothing happens, still balanced. Okay? So what we have is a unilateral AS on the left side. And the way that we'll elevate foot plate, set the drops, put the headpiece level for this one, okay? We'll instruct him to rotate his face, no, not this way. and we have an AS occiput, so we're gonna make contact on the anterior part of the mastoid. You can use either hand, as your nail hand, whichever one you're most comfortable with, okay? To stay as a square, and what we want to do is just rotate that occiput from anterior to posterior. So we'll make the contact, and it's not a recoil thrust, it's a sustained type toggle. So we'll roll in and set the drop, thrust. Okay. And after that adjustment, we'll do the post check. The legs are balanced. We will bring them into flexion and they stay balanced. He rotates his face right, center, left, center. They stay balanced. And we'll post palpate. Unilateral AS. Okay. Yes, ma'am.
You said when we first started, you said he rotated his head left, and left gets shorter, and rotated his right, it's no change.
Right. Nothing happens. Okay. Okay, the unilateral PS. Like the unilateral AS, we'll start with balanced legs. We will bring them into flexion and they stay balanced. And let's say that he rotates his face to the left and the left draws short. I mean, not the left draws short, the right draws short. Back in the center, and he rotates his face to the right, nothing happens. Okay? So we have is a unilateral PS on that side. So we'll have him to rotate your face this way. Okay? This time we will come behind the patient. We'll contact the posterior part of the mastoid. The table position is the same, the drops are set, the headpiece is level. You still can use either hand. And we're right behind that occipital mastoid groove. We'll roll in. And like the other one, it's a sustained toggle with the drop. Put his head back in the center. At this point, the legs are balanced. We will bring them into flexion and they stay balanced. He rotates his face right, nothing happens. Center, left, nothing happens. They stay balanced. And we'll just look up. Okay. That's unilateral PS. Question about that?
And you differentiated the AS and PS by the palpation?
No, by the leg shape. If he turns his head to the right and the right leg is short, okay, that's going to be an AS. But if he turns his face to the right and the left leg is short, then that would be a PS. Okay, are there any other questions about that one? Unilateral AS or PS? Okay. What do we do next?
We got exterior field.
Exterior field. Okay. Exterior field, like the bilateral and the contralateral, we will start with balanced legs. So the legs are balanced. We bring them into flexion, and when we bring them into flexion, one gets shorter. Okay, that's the exterior field. So now we'll check the cervical syndrome with the legs in flexion. It could be XD with cervical involvement, XD with sacral, lumbar, pelvic involvement, or any combination. Okay? So let's say that Luis turns his face to the right, and they balance out. Back in the center, he turns his face left, nothing happens. Okay? So we know that we have a cervical syndrome on the right side. So he turns his face back to the right. We palpate for the tendons at the set capsule, set the drop, do the adjustment. Back in center. The legs are still balanced in extension. Now when we bring them into flexion, they're also balanced in flexion. Okay? So now we need to bring them back down to rule out the bilateral and the contralateral, or the unilateral AS or PS, okay? So we'll bring them back down. This is chasing the deer field, okay? He turns his face right, and nothing happens. It stays balanced. He turns his face left, nothing happens. It stays balanced. And without that. That's the HD with just cervical involvement on one side, okay? It could have been right and left, okay? But, you know, you would just correct that if it is, so you know, you already know how to do that. HD with, let's say, cervical and pelvic involvement. We have balanced legs. We bring them into flexion, and let's say that the right draw short. He turns his face right, and it balances out. Back in the center, it gets back short. He turns his face left, nothing happens. Okay, back in the center. So, coming up, and set the drop, palpate and find the segment. Do the adjustment. The legs are still balanced in extension. We'll bring them into flexion. This time when we bring them back into flexion, the right draw short again. Okay? So now we need to find out if we have corrected the cervical problem. So we'll go through the cervical syndrome check again. So he rotates his face right, nothing happened. Left, nothing happened. Okay? So we fixed the cervical problem, but we have another problem somewhere else. And we have enough trigger points to proceed with negative correction above and below the waist, okay? And let's say that instead of doing this prone, I'm going to do this supine. Give you a break, Louis. Thank you. When the patient goes from prone to supine, the next thing we'll do is check the spinal balance, and the legs are still balanced, okay? They were balanced when the patient was prone, and they're still balanced. But we have enough trigger points to proceed with the negative correction. So we'll check the supine trigger points to see if there are any present, and we'll make this a two-part move with a rotational component. We'll set the table, thrust. Now the leg has become a little short, okay? So we'll flex this one, contact with the thenar pad right over the anal ligament, get a little bit STI, set the table, and we'll thrust, since it's on the right side. If we want to get a little torque into it, the torque will be a counterclockwise type torque. Okay, so they're balanced, but we still have a little bit of rotation, and let's say that the rotation is a little bit external. We'll set the drop, correct the rotation. He's balanced, rotation's corrected. Check supine triggers. Goes back to the prone position. The legs are still balanced in extension. When we bring them into flexion, they're also balanced now in flexion. Okay? So now, if the legs are balanced in flexion, there's no need to do the cervical syndrome check in flexion. Okay? But we still need to rule out the bilateral, contralateral, and the unilateral. Okay? So Louise, turn your face right, center, left, center, okay? And there's nothing going on there. And post check trigger points, okay? And post palpate, cervicals and lumbar. Now, you don't have to do it in that order. If you want to do trigger punch first, that's fine. And, yeah, I need to do anything else with the HDO field. Because it also could be sacrum, lumbars, and you just treat it just like the negative. Well, if you don't find trigger points, you move to where? Fifth lumbar, right? Nothing with fifth lumbar, you move where? Sacrum, then to the gastroc. Question? I think that was the last leg check move that we had, right? He also has cleanup moves, and some of these we've already done in the previous quarters. The side slip is done and can be done in thoracic or lumbars, okay? We'll find tenderness on the opposite side of the lateral incision, so if it's moved to the left, then we're going to have multifidi and rotators tight on the right side. And stance squared, you could use either hand, superior or inferior. Usually if you're in the upper thoracic, people will use the superior hand. If they're down near the lumbars, they use the inferior hand. So, but it's entirely up to you. It really doesn't matter. Make the contact, set the drop, put it back on. Post-foul play. Side posture, a rotation component, level your right side, Louise. This one's done primarily in the lumbar spines. We'll use the drops, we pronate the patient a little bit. The nail hand is the inferior hand. We're behind the patient. Find the segment to be corrected. Hold in with the pisiform, the tailor set, and draw straight down, lateral to me. Okay. Some of that one. Back wrong. May have to help me with it. Okay, we'll check sacral restriction. If we have bilateral sacral restriction, that's an indication of what apex posterior sacrum. And we'll correct that one. We'll set the drop, flex the legs, and palpate the apex of the sacrum down there, the third, fourth sacrum, and thrust the apex, P-Day. Or a little bit P-Day upside. The other one, lumbar distraction, so the fifth lumbar has dropped inferior, and the sacrum has moved away from it. So with that one, we're getting there. First, let's make contact on the fifth lumbar with the heel of the hand, right underneath the spinous, like that. And this is more or less not with the drop, but we'll open up raise up the pelvic section, and just sort of stretches it like that right there. Lift the fifth lumbar back up. Oh, forgot about that. I'll come back to that. Remind me. Turn to side, Louise. Got the Brahma blocker. If we were doing a spondylo, we would have the patient supine and we'd have the sacral blocker inserted. And if I should give you this on the test, you can just tell me. I may forget to bring it like I forgot to bring it today. And we want to have the fifth lumbar right between these, the space between the lumbar and the pelvic section. Flex the legs. Stand on either side. We use the ignore, just lateral to the umbilicus. Okay. The table is set to drop, but we don't thrust. We just put a little bit of pressure until the table just slightly drops. Okay. Grade 1, grade 2. Okay. Anything greater than grade 2, then you send them to the surgeon. Okay. Not just joking. I'll send them to the surgeon. You know, I had a patient once when I was in school. This guy, I don't know if I told you this story or not, but he was a paratrooper in World War II. And he jumped out of a plane, I think in Normandy, France, I believe. And he couldn't walk for about, I don't know, a year. So he stayed in the hospital over there for about a year. And they said he would never walk. But he was able to walk again. And he used to work at Sears. I worked at Sears when I was a student here. And he repaired lawnmowers. And he was always crawling around on his knees, on his back, and sometimes his back would hurt. So he knew I was going to chiropractic school. He asked me if I would take a look at his back because he used to go to a chiropractor off and on years ago, and it helped him. So we brought him here. We x-rayed him. The guy had a grade 5 spondylolisthesis. His fifth lumbar was sitting in front of his sacrum. Yeah. But I didn't do anything to his sacrum. Or his fifth lumbar. Yeah, he had a grade 5. It was completely off. I couldn't believe it. So we done that one. The anterior thoracic. If we have the blocker, we'll insert the blocker. Okay, underneath the spinous processes of the segments that's anterior, usually what that's called Pottinger saucer. We'll grasp the shoulder, set the drop, and thrust. Okay. Didn't know the drop was set, Louis. I got to collect for that. Okay, and if you don't have the dorsal blocker, you can use your hand. Okay? You just roll them off a little bit, put the hand underneath the spinous, just rolling back. You can do this with the drop or without, and then just thrust into it. Okay. The other one that we done was the rotated rib head. I say we have a lot of pain and tenderness at the costosternal junction here. This rib palpates like it might be a little superior on the anterior. So we'll also palpate that same rib on the posterior side. Come up a little bit more. Okay, make the contact on that rib, contact this one, roll back over, we'll set the drop, and thrust like that to correct the rib. Now if the rib's going in the opposite direction, then we'll thrust this way. Okay. Elevated rib cage. This side of the rib cage is up and this side's down. We'll stand on the side that's up. We'll make contact on the pectoral muscle with the superior hand, like that, inferior portion of the rib, and we're doing that with the drops. Okay? Correct the okay. Did I do any more? Clean up. So that was it.
There are 4.
Okay. The overcompensated cervical syndrome. With this one, the subluxation has occurred at C2. We've been adjusting C2, but it's just not holding. Okay? So in this case, from motion palpation, we probably have fixation at the T1 rib articulation, and that rib's a little bit superior, opposite the side of the cervical syndrome. And also, right at the area of the trapezius, pain and tenderness of that particular muscle. Okay. So, come up to the patient, turn your face that way, Louise, and palpate that rib, make contact on that rib with nail point 8, cup the ear, rest your arm on the back, the table and lumbar section set to drop, and we're thrusting SI on that rib to bring it back down. Okay. And post-shag legs balanced, no cervical syndrome, and the patient starts holding their C2 adjustment. And I think that was it. Is that it? Did I forget anything?
With that stair stepping pattern, the spinal process, they're